it's really an honor to introduce Dr. Shakir, friend for, I don't know, 30 years maybe.
Yeah.
Okay. So it's an honor actually to present Dr. Shakir Bahzad, close friend for more than maybe 30, almost 30 years. We've been together in Saskatchewan, in McMaster, in Hamilton, Ontario. So he's a consultant in clinical as well as molecular genetics. He's also board certified in anatomical pathology. We achieved our bachelor degree together from Kuwait University, and then we went together to Saskatchewan, he's board certified in anatomical pathology as well as clinical pathology from University of Saskatchewan. Then we moved together again to McMaster University as well, where he did cytogenetics and molecular genetics. He's currently working at the genetic centers. He's running the general hematology and cancer genetic clinics as well in the unit. And he works both in Ghanim Al Ghanim as well as in the cancer center in Kuwait. It is definitely an honor. He's a member of several committees. He oversees so many labs. And honestly, apart from what's written, he definitely did a huge jump and improvement in every single service he joined, whether it's in the maternity hospital or the cancer control center. Very happy to have him today. He'll speak about personalized medicine, which I really believe in, at least in my patients. I mean, if you read any new guideline, you will see personalized plan or personalized medicine. So definitely Shakir will be the best to talk about that. Thank you, Shakir, for being here.
Thank you very much. Thank you. يعطيك العافية. Thank you very much. You make me blush. So it's an honor to be here, and I really like cozy theaters, cold, but please don't fall asleep. I promise you, I'm not gonna get too. Okay, what happened here? I'm not gonna get too technical because I've been accused of doing that before. So I'll make it as easy and sweet as humanly possible. So as Dr. Ali said, my name is Shakir Bahzad, and I divide my time between KCC and KMGC, which is the Kuwait Clinical Genetics Center. Oh, okay, sure. So let's start. So I have nothing to disclose. So the objectives of this lecture is just to introduce you to precision medicine, which also has many other names. And I'll give you a couple of examples on each branch of precision medicine and what's available currently in Kuwait and what are we planning for the near future. So, okay, so let's start with the definition. So precision medicine. So precision medicine is an approach to patient care that allows doctors to select treatments that are most likely to help patients based on a genetic understanding of their disease. This is the simplest one I've encountered. It's definitely not as simple as that. So precision medicine is always confused with personalized medicine. Lots of people, even geneticists, they mix. They think that this is synonymous, so they use them interchangeably. But there is a slight difference between the two, and usually between geneticists, when we talk about precision and personalized, we use the proper terms. But when we talk to other doctors, we let it slide, so we don't get offended. So precision, is a single word, means that to hit a target in the same place over and over again. I'm sure you remember that target cartoon with the arrows on aiming at one place. So precision medicine aims to create medicine models that target a similar feature of a disease that appears in multiple diseases or cancers in some cases. So it means we target, we target a specific mutation in a group of people. They share the same mutation, which is in contrast to personalized medicine, which in personalized medicine, we're talking about an individual, a patient, a person with a combination of genetic mutations unique to that person. In precision medicine, it's targeted, so it means that we're looking for a single target that's shared between a subgroup of patients. Okay, so that's actually what I just said. So when you say precision medicine, so for all practical reasons, I will use precision medicine as a big category here. So precision medicine is divided into two big categories. One is the targeted therapy. So this targeted therapy is mainly used in cancer patients. And the other branch, which corresponds to the personalized medicine, and this looks at the drug response in these patients. So these are two different categories, different tests, different approach, and different drugs. So let's delve a little bit deeper here. So both branches, they depend on the genotype of those patients. So it's precision medicine in general is based on genetics, so on the genotype of those patients. So pharmacogenetics, and we have pharmacogenomics. Again, they're different, and the simplest way to put it is the role of genetics in drug responses. So just a quick word on ethics versus omics. So in genetics, we're talking about a single gene in a single patient, and how this version of the gene interacts with the drugs that you give. In genomics, we're talking about several genes, anywhere between 200 and 300 or 400 genes at the same time. So just to make it a little bit simpler, so genetics, simple interaction; genomics, complex interaction. Okay. And just a quick word on genotype versus phenotype. So we do have, do we have a pointer? A pointer? A point? لا لا خلاص okay. No problem. Yeah. موجود؟ إيه بس ما يطلع عندي. Yeah, okay. I got it here. So it's just the difference between genotype and phenotype. So it's here, the first part is the genotype. So it's the mutations that the patient has. So in number one, we do have the normal, which we usually call wild type. So this is the sequence of a single gene, which is the 2D6. And the second one, so number two, you have a mutation. Instead of T, there is a G. Okay, so this alters the gene function in a radical way. So this is the genotype. So this is the genetics of these patients. Now, those patients, so number one, will respond well to cholesterol medication. Any statin, it's not going to be a problem for that patient. The second one, only that difference on that specific place, which is T, which is G, instead of T, this patient will develop hepatotoxicity just because of that specific mutation. So now you know the difference between genotype and phenotype. So in treating patients generally, we still use the traditional treatment way, which is a standardized drug in a standardized dose for all patients with the same disease or same condition, regardless of how they're going to respond to the drug. So these patients with the same disease, some of them will respond normally. So some of them will have toxic responses, some of them will have no responses, and some of them will have something different altogether. So this way does not work anymore. Actually, it works for normal responses, but not for all of them. And we're missing lots of others, and we might be causing harm in a subgroup of people who will have a toxic response to those drugs. So I'm sure you've always wondered, why do some people need twice the standard dose to be effective? So you give somebody like the normal dose and they don't respond, and you increase the dose, they start responding. And why does a drug work for somebody and does not work for somebody else? Although they might be even brothers, like siblings. You get same condition, you give this person a drug that works, you give the sibling, and it does not. So and it happens actually a lot. And why do some people get side effects but others do not? Okay, so we vaguely had an idea of what was happening, but when the Human Genome Project came out, was published in January 2001, and then the newer version was published in 2003, we had a great advances in precision and personalized medicine. So we started to understand why people respond to some drugs and people don't. So it is individualized, and we are all different. So believe me, we are way more different than you think. We have different proteins, different enzymes, different versions of enzymes. And some of these differences will translate into different responses. And that's why personalized medicine is important to everyone. And this is just an example. So when you give the drug, when you administer the drug, it affects the drug is affected on every level from the time you give it until the time it's excreted. So for the delivery, so for the pharmacokinetic, so it affects absorption, distribution, metabolism and excretion, and this all, well, if not all, most of it depends on the genes, and well, it will depend on your genotype. And then when you reach the site of action, again, the targeted area, the mechanism of action, the drug response, in general, it's pharmacodynamics, also affected by the genes that you have, the versions of the genes that you have, and then it all depends on your genotype. Okay, so what's the logic of pharmacogenetics? This is what we usually do. So we identify the variation in drug response. So we know this drug has significantly different responses in different patients with the same condition. So we try to associate this with the genetic variation. So we do a couple of genetic studies just to locate where the difference might be between different patients, and then we evaluate its clinical significance and then develop a screening test for it, and then depending on these tests, we individualize drug therapy. Okay, so what does it promise us? So it promises focused treatment depending on their genetic background, and to reduce side effects and improve response and better understanding of drug interactions, which might be very complicated sometimes. So this is just an example of variability of disease. So if you take leukemias and lymphomas in the 1950s, we had no idea how they affected the human body. So at that time, it was called disease of the blood. And if you look at the right-hand side there, the 5-year survival was 0. So you have leukemia, game over. So as we started subcategorizing leukemias and lymphomas according to their morphology, the improvement, again on the right-hand side, started to increase. And then till 2007, when the WHO classification came out with the 38 leukemia types, the survival reached actually to almost 70%. Now in 2018, we have the specifications, the types are all genetically dependent. So before it was on morphology. Now all lymphomas, all leukemias depends on genetic background. So you see, you look at a leukemia or of any kind, and you decide what type is it, and then you have to do genetic testing to decide the treatment and the subtype. So the ultimate goal is to give the right dose of the right drug for the right indication, for the right patient at the right time. So let's go a little bit deeper now. This is an example of the many genes that we have. So we have the cytochrome oxidase, the P450. I'm sure all of you know it even from your medical school. So we have 17 different families. We have around 1,000 enzymes in those families, and humans use roughly 50, a little bit more than 50 of them. The important ones are family 1, 2, and 3. And the subfamilies just below them there. Some of them are really important, which is the 2D6. once you start ordering these tests, you'll start knowing which genes that you need to order. So the 2D6 and the 3A. We also have the 1A and also the C19. These are important ones. So let's go a little bit. This is just an example of what difference does it make if you have different versions of those genes. So if you see here, the 2B6, around 4% of Caucasians, they are poor metabolizers, so they will have the effect of these drugs will be different in them, and might be non-effective or toxic in them. And just keep in mind, these are in Caucasians, so we're mostly talking about European whites. There are few studies studying our allele frequency in our area, mostly in Saudi Arabia. A big portion of this country, actually, they have ancestry in Saudi Arabia, so it might reflect some of the genetic background there. But again, we need our own, of course, because these numbers, as we started doing other genetic testing, we started to notice that our genetic makeup is different. So in breast cancer, for example, our Middle Eastern, they tend to have the peak of this cancer actually a decade earlier. Also, the peak of colorectal cancer, again, a decade earlier in Middle Eastern backgrounds. And we still don't fully understand what's happening in those people. So another important one, so the 2D6, so up to 10% of Caucasians will have will be poor metabolizer, and these are drugs that readily used. So you will see at least 10% of them will not respond. All will respond in a very exaggerated manner. I'm trying to. This is oversimplification. It's much more complicated than this. So I just don't want to go into specific genetics of each one of them, but we'll just see a couple of examples. So. So we're still talking about the drug response branch. So as I said before, we have two branches: the targeted therapy and the drug response branch. So usually patients are, according to their genetic testing, are classified into these categories. So poor or slow metabolizers. So these patients, they have versions of those genes. Of a specific gene that it's either non-functional or very slow in its function. And it depends on the drug. So if the drug is administered in its active form, so this patient will not metabolize it into an inactive form, and this active form will start accumulating, and the patient will experience toxicity. And in case of drugs that are administered in pro-drug form, so they are not transferred into the active form, and you'll not see any response. It's not going to be effective in them. It depends on the drug itself. Intermediate metabolizers, this is usually 50%, but it goes from 25% to 75% of the original activity of the enzyme. And these are just example of different ethnicities. So we had this problem, especially in some drugs in cardiology, and in so the 2D6, it affects cardiology, many cardiology drugs, psychiatry drugs, cancer drugs, immune modulators. So they are all metabolized in some way with the 2D6. And you see Asians, especially Filipinos, they have a problem with it. So you give, let's say, a Plavix, and there is a 50% chance that this Filipina is not going to respond to it, or it's going to have actually toxicity to it. Okay, so we do have the other categories, so extensive metabolizers. So the EMs, these are the normal ones. So the name probably is a misnomer. So it means that this is the wild type. This is the normal. Vast majority of people will handle this drug normally. We have the ultra metabolizers. They have a version of certain genes that metabolizes these drugs in faster and faster than the normal. And this again can create other problems, either that the drug is not effective if it's administered as an active form, or increased toxicity if it's administered as a prodrug. And again, the ultra metabolizers, which is a little bit here. Okay, so you see here Saudi Arabians. This is one of the studies done there, and it's 1 in 5 for 2D6 will be 1 in 5 people in Saudi Arabia will have this exaggerated response, and 1 in 5 is a lot. So 21%. So we see it here. We see this especially in the psychiatry. I get lots of calls from the psychiatry center, and with people having toxicity to normal dose. Okay, so as an example, codeine. So codeine is commonly used opioid, and it's a prodrug. So it has to be metabolized into, I don't know if it's not projecting well, but has to be metabolized through 2D6 into morphine to the active form. So, and around 7% of Caucasians are missing 1 copy of the gene. So codeine does not work effectively in these people. So it's not converted into morphine, into the active form. So it gets eliminated without the desired effect. And we've seen it here. I'm suspecting that the alleles, the ineffective alleles here, are a little bit different, a little bit more. So we're talking about alleles now. So just a small definition here. So allele is a variant of the gene. So we have a specific gene with a specific mutation. So this is one version of the gene, and in that specific position, if you have another nucleotide, this is another version of the gene, and so on. So we can have endless numbers of endless versions of that gene. So let's say on position 7, you have a T. This is the wild type. If you have a G, this is another variant of the gene. So this is another allele. And on position 250, you have another one, and so on. And specifically for this purpose, for drug response, we tend to name it, convert those mutations into star alleles. We convert them to star alleles just to make it easier for our interpretation. So here, what we call star alleles. So here, this is the gene, and you have the star 2. It means version 2 of the gene. Usually, the wild type, the normal version of this gene in the general population is called star 1. That's the usual. And star 2, it means that there is a mutation. So in this specific gene, so the C19, we have this mutation. If I see this mutation, I will call it this version, which is star 2, and so on. So star 3, star 4, and so on. And this mutation could be a single point mutation, a small deletion, a small duplication, or exon deletion. It depends. It depends on the specific or the unique structure of that gene. Okay? Okay, so this is how we interpret the results. So if we have, so these are the star alleles that are the possible versions of the 2D6. Let's say you have a patient with whatever, and you started giving codeine, and he or she did not respond. And we did the test. We did the sequencing of the 2D6. So I'll go through them, but from down up. So if you have these versions, so of every gene, we have 2 copies, right? One from mom, one from dad. So if you have the star 4, which is from here, which is the non-functional variant, this patient will be a poor metabolizer. So no matter how much codeine you give, it's not going to work. If you have any combination of those, a response is 0, so the activity is 0. This gene is rendered non-functional. If you go a little bit up, this is the 50% to intermediate metabolizers. This one will be 50%, but the other one will be 25% because it's a combination between two different categories. So you go with the reduced effect. So any version of those, so 1, star 2, 27, will be normal function. And if you have normal function, so 1, 1, and it's duplicated, this patient will be ultra metabolizer. Okay. So this is what you see in the guidelines. So if you have a poor metabolizer, so the function is greatly reduced, and we'll suggest alternatives. What could be? So we'll tell you this drug is not just. Try to search for alternatives, and we'll tell you like you can use this, or that. And it goes, so the extensive metabolizer, this is normal. The intermediate metabolizer, give with caution. And then if it's ultra metabolizer, we'll do the same, but this is the opposite, and we'll also give you alternatives. This is for another drug, so this is another gene, so 2C9, and this is for phenytoin. Again, each gene and each drug will respond differently. So there is no one category for specific genes or specific drugs. So these versions are a little bit different. So again, as I said, star 1 is usually the wild type, but there is the other copy is mutant. So for this specific genotype, so you have to reduce the drug by 25%, and this is what you expect to monitor in those patients, and so on. This is what we use. This is our machine, and we do have the machine, but they have their own already built kit, and when I saw that kit, it was actually much less than I anticipated, much less than I wanted it to have. So they have different small kits. So we decided that we're going to design our own. So this is the one I designed. So it has 51 genes with 180 variants, and it covers approximately the response of 300 drugs. So it's being manufactured, and once it's done, we'll get a starter kit and start the validation process. So we used their already manufactured one, but it did not include a lot of genes. So there were lots of genes not missing there, and there isn't in the market. There isn't one that has all the genes at the same time. So we just decided to design our own. And this is the report this is a sample report that you're gonna get once it's done. So this is the first page, and has the summary. So when we do for all of them, for all 51 genes, so you'll have lots of responses for other for most of the genes and most of the drugs. So here it will say consider alternatives for these drugs, alter the dose for these drugs. You can use these drugs the manufacturer way, so normal response, and proceed with caution with the last category. And then the details of this is the rest of the report with the details. So it says here no with a big red cross. It says like don't use that because this patient is intermediate metabolizer, and consider the alternatives, and so on. And then according to the symbol, you need to decrease the dose or increase the dose. And this is it goes on for all the drugs included in this test. So now to the other branch, which is the targeted drugs. So these are for cancer mostly for cancer drugs. So these drugs are only effective if you have a specific mutation or the lack of a specific mutation. So the treatment of non-responders puts these individuals at unnecessary risk of adverse events. So if if this drug needs that mutation to be present to act, if the patient does not have this mutation, it's not going to act, and he or she will get all the side effects. So this is what we call this is the part where is precision medicine, and this is what we do, and this is what we do currently for the past 3 years now. So this is just an example. So gefitinib, which is used in non-small lung carcinoma, adenocarcinoma. It's the drug is anti-EGFR, and the EGFR is just let me just show it to you here. So just in the normal process, this is the EGFR. It's a big protein, a transmembrane protein, and if it's signaled, if it's stimulated, it will activate all the cascade, and it goes to cell growth and proliferation. So what happens in 25% of all lung cancers, of all adenocarcinomas, that this EGFR is mutated, and it has an activation mutation. So it's perpetually activated without any EGFR or any ligands that actually goes there. So the cells will go on for cell growth, and they don't stop. So the drug will, if the mutation activating mutation is there, the drug will stop it. If the activating mutation is not there, the drug won't be effective in these patients. So this is one of the panels that we do. So we include all these genes for cancer, and we do have different panels. We have a small panel with 22 genes. We have RNA panels with translocations, and this panel is a comprehensive one. So this is just one of the reports. So patients with adenocarcinoma, with lung adenocarcinoma, they come in, usually they come in stage 4, and there's nothing else we can do for them. So this is what the oncologist would usually say. So they're progressing on chemo, they're not responding. Some of them actually come directly to the ICU. And in the older days, so 4-5 years ago, they're just palliative. There's nothing else we can do for them. But now, with this test, with the genetic testing, so we use the NGS. If they have the EGFR, so 25% of them will have it, so they are eligible for EGFR TKIs, tyrosine kinase inhibitors. And let me tell you, it's I've seen patients come to the ICU, and they are critical, intubated. And then for something, the oncologist would tell me something, this patient has a life expectancy of like 2 weeks. We do the test, and he was like, I need this test to be done now. I need the results. And once we get it, and once we start this class of drugs, many of them, around 70-75%, will respond, and I've seen them go back home. And for the next couple of years, they're fine. So otherwise, they would have died. So this is a miracle drug. So anyone with stage 4 lung adenocarcinoma, if we don't do that, this is actually a crime. We're condemning them to die. And in the process, we found TP53, another mutation there, but we still don't know the effect, if there is any clinical significance for that. So in the future, once we accumulate lots of mutations, we can do some studies on them and see if they are effective or not. So this is another one which also had lung adenocarcinoma. So we did the EGFR, it was negative. So it was a she, and she was stage 4, she had brain mets, she had seizures. So the oncologist was a little bit disappointed. So EGFR is negative, so we can't use that drug, that class of drugs on her. We did ALK, and there was no translocation, so we cannot use that class too. and ROS1 was negative. So, but when we did the comprehensive, the bigger one, we found something unexpected. We found a mutation that's ERBB2, an exon 20 insertion. This is a very specific one. This is the HER2. You know it as HER2. So in this mutation, the patient is, for that very specific mutation, the patient is eligible for a drug which it's a modification of the Herceptin. So the Herceptin itself, there's another something added to it, and it's called Kadcyla. And now she has hope. So she came in for palliative, and she wasn't eligible for anything. Now we found this mutation, and now she can take it, and it usually works. A high response rate, and I hope to see her home soon. So another example is colorectal cancer. So colorectal cancer is actually exactly the opposite. If you find a mutation in the KRAS, NRAS, BRAF, so this patient is not eligible for the drug. So we need the patient to be wild type to be eligible for the drug. And we have a huge list. I'm not going to go through it. So some of them, well, like HER2. So if we find the amplification of HER2, so as in the breast, they are, in the guidelines, there's still no treatment, but we're using it off-label. Okay, so this is continuing the list. So MSI and the others. In combination of those, if we do the drug response, so targeted, and then the drug response, so these are the same family as the 2D6 and the others. So it would be a very tailored, very specific treatment for that patient. So we'll tell them from the targeted, you can give this, this, and that. And for the drug response, you can give this, this, and that, and not this, this, or that. So usually the patient ultimately will get a very tailored treatment for her or him. So this I'm almost done. This is when we started. So when we started, it was just a storage room. This is when the department head actually emailed me before actually finishing from Canada. So before graduating, he emailed me this blueprint, and he was like, okay, I need you to create a molecular lab in this space. And I didn't know how, on the blueprint it doesn't show much. So when I came and saw it, it was a storage room in the basement, and it's in the ground floor, and it's something like 9 by 11, and that's it. Like so many, it's a storage room. And he wanted me to do a molecular lab in that. And when I told him, I was like, okay, what is the budget for this? He was like, what budget? What are you talking about? So I was like, okay, this needs money. So this is before. So it was full to the ceiling with broken chairs and desks and stuff. So we started cleaning. It was myself and some of the cleaners and the technologists. I have very enthusiastic ones. And this is the before, and this is the after. So we did, I had to sit down and become an engineer myself and try to draw the blueprints for a molecular lab. And I insisted on some qualities. Just to keeping in mind accreditation purposes. So this is the lab, this is where the magic happens, and this is when we produce our first report. And these are my technologists, so the four of them are standing behind. So these are miracle workers. They're young, they're enthusiastic. They don't care about on-call time. They stay overtime. Some of them will stay till like 10 p.m. with me just to get those results for the patients. And those technologists are really emotional, and they get really happy when they get the mutation that the patient is going to get some treatment, and they actually literally cry when they don't get the mutation, so the patient is not going to get the treatment. So it's every day working there. Every day it's actually an emotional roller coaster. And that's it. You're welcome. Okay.